Let's talk about healthcare in the country and the impact of privatizing healthcare in Kenya. So, some collaboration has taken place in researching what's happening in the healthcare sector in Kenya. And the people who did this survey, the research, and they released a report yesterday, are in the studio with us. One of them is Dr. Nicholas Orago. He's the executive director of the Economic and Social Rights Center called Haki, Jamii. Dr. Orago, karibu.
Asante sana.
And then we also have Rebecca Riddle. She is the co-director of the Human Rights and Privatization Project at the Center for Human Rights and Global Justice at the New York University School of Law. Good morning, Rebecca.
Good morning.
Welcome to the Situation Room. We normally have one hot seat, but because you're two, so you'll share the hot seats. Welcome to the hot seats of the Situation Room.
Thank you so much.
We first need to understand what this research was all about. But we first want to know Haki Jamii, the organization, the Economic and Social Rights Center. What is that and what do you do?
Thank you so much, Eric, for having us. The Economic and Social Rights Center is a national non-governmental organization that works on the realization of economic and social rights. We were established in 2004 and officially registered as an NGO in 2007. And we have programs around land and housing. We have programs on health, water and sanitation. We have programs on education, and we have programs on research and budget analysis. So if you have monitored evictions in this country, you cannot have missed Haki Jamii, because even currently we're the ones undertaking litigation on behalf of Mukuru Kwanjenga, the people who have been evicted at Mukuru Kwanjenga. And if you also followed the news earlier this year, the demolition of the mosque in Kibos in Kisumu and the demolition of the Nubian community settlement in Kibos. We have actually litigated that and given them back their land, and also constructed 83 houses for those who had been evicted. So we work around land, housing, evictions as the main work that we do. But we work on economic and social rights generally, including the right to health. And that's the reason why we are here today.
Who finances you?
We have support of different organizations that support the work that we do. And we also collaborate a lot with different institutions, like the New York University, that this collaboration has brought us this particular report. Yes.
Daktari, are you aware that you've judiciously avoided answering his question? Is it something that you can easily talk about, or is it something that your work doesn't allow you to talk about?
No, our work allows us to talk about who funds us. We have different funders for the work that we do, different foundations that fund the work that we do. You want me to mention specifics?
How very, very astute of you. Yes, thank you. That is precisely what I'd like you to do, yes.
Yes, our work on land and housing is supported by Miserio, which is a German foundation.
Yes.
Our work on health is supported by the Open Society Foundation, and also New York University, through this collaboration, also support our work on health. Our work on reproductive health is supported by PPG, Planned Parenthood Global, and our work on education is supported by Open Society also. Yes.
Do you have any local organizations supporting you?
We have partnerships with local organizations and networks. For example, the Housing Coalition is a network of organizations that work on housing in Kenya. So we support each other to do work that we do around land, housing. Amnesty Kenya, Open Society, and all those, we work together to ensure that we advocate for the rights of vulnerable in community, and to also ensure that we achieve legal reforms that are actually protective of the vulnerable in our communities.
From what you just said, one gets the distinct impression that organizations that are nestled abroad and in other countries seem to be more concerned about our issues than we are.
Not necessarily. We have made efforts actually to get corporate support for the work that we do. And we have engaged Safaricom, for example, in some of the work that we do. We have engaged KCB in some of the work that we do. But as well as I do, corporate social responsibility is not as entrenched in Kenya as it is entrenched in other countries, and that's the reason why sometimes we have to rely on financing and support from others.
Oh, I applaud the support we get, and I am delighted that there are people who actually understand the need to support these problems. My beef is with our people and our organizations because the problems are here. And all these organizations, much as we say they don't have very strong corporate social responsibility networks, but they live here. So they have a closer handle on what actually happens, or at least one would hope so, that they can actually see and understand what happens. And if you're talking about the provision of solutions, that they'd be quick off the mark in supporting. But there we are.
We will continue with that as we hear about this report that you released yesterday. Rebecca, you work at the Center for Human Rights and Global Justice at New York University. Tell us about the center.
Yes, and I want to also echo Nicholas's thanks for the opportunity to be here today. We're really pleased to have the chance to speak with both of you. So I work at New York University's Human Rights Center. We carry out a number of projects around the world, and specifically I direct the Human Rights and Privatization Project, which focuses on trying to understand in a better way the human rights impacts of privatizing services around the world. There is a real push to move social services and other important public goods into the hands of the private sector for various reasons, and we're trying to get a better grasp on what that means for people, and particularly for people from low-income sectors. This grows out of work that I did previously, working as the senior advisor to Philip Alston in his capacity as United Nations Special Rapporteur on Extreme Poverty and Human Rights. Of course, he's better known in Kenya for his work as United Nations Special Rapporteur on extrajudicial executions.
Yep.
But after that, he spent a while working on poverty. And so I work with him at New York University's Human Rights Center, carrying out projects in various countries. And we were so pleased to have the chance to collaborate with Haki Jamii to better understand how things have gone for people in Kenya.
When you talk about privatization of Kenya's healthcare, what do you mean?
Yeah, clearly the country has not sold off its public health facilities. What we mean when we say privatization is, on the one hand, the government has intentionally sought to increase the role of the private sector in health. A lot of that has come from a push made by development actors to promote the role of the private sector in health. This has occurred alongside underinvestment in the public healthcare system, which often drives people to the private healthcare system. So that combination of a push to increase the role of the private sector with chronic underinvestment in the public system is what we mean when we say privatization, because it has led to a rapid increase in the role of the private sector. And so you see government policies such as, efforts to pursue and sign on to public-private partnerships that bring foreign companies into the medical system, or efforts to include private facilities in national programs like Linda Mama, and a range of initiatives that have really sought to grow the role of the for-profit private sector in healthcare.
So it's both in policy, in financing, and in underfinancing the public.
Yeah, precisely. It's a push to increase the role of the private sector as a financier. So you have private equity firms from around the world investing in healthcare in Kenya, investing in hospitals in Nairobi. And then you also have a push to increase the role of the private sector as a provider of healthcare directly in clinics.
What I find interesting, I have read the report that you put out. What I didn't see, maybe it was there and I'm the one who missed it, but is there a distinction between under-providing for public health care and the mismanaging of what is actually provided for public health care, and how that plays into what we then see as a complete and a near absence of required healthcare provision for those who need it? Those two things, resources, availability, availability, management.
Maybe if I might respond to that. If you look at the country, our country, and the way that it has invested in healthcare, the Abuja Declaration that Kenya has signed on requires that there has to be at least 15% budgetary allocation to health for each and every country that has signed to it. But Kenya has consistently only had half, almost 7% of its budget going into healthcare. And even healthcare has been devolved to, especially healthcare provision itself has been devolved to the counties, while healthcare policy has been maintained at the national government level. But if you see the resources that go to the counties for the actual provision of healthcare vis-a-vis the resources that remain at the national level, we are seeing that even with the 7% that has been budgeted for health, the majority, the lion's share of that money remains at the national government, and very little of it goes to the county governments that have the responsibility to actually make provisions for healthcare. So when you go to the counties, you find that the counties are building some structures for healthcare dispensaries and clinics, but the empowerment of the human resources to provide healthcare and the provision of medicine and other technical components of provision of healthcare is actually missing at the county level. So in essence, the underdevelopment comes with lack of financing, but it also comes with mismanagement of the financing that is available. We have read Afya House scandals, we have read the KEMSA scandals, and we have known that most of the money that goes into health, as in other departments of government, actually gets lost. So in essence, you're talking the underfunding itself has made it impossible for people to have effective and quality access to healthcare. And that's the reason why people are now, we say de facto privatization, which means the lack of investment in the public health system then forces people to go to a private health clinic. We had occasion to ask a few people, if you were sick and you wanted to go to hospital, which hospital will you go to? And very quickly they said, I'll go to a private hospital. You ask them why. They'll tell you, one, the private hospital is nearer me or where I am. The public hospital is further. And when I go to the public hospital, I have to make a longer line to get services. So that's a whole day. If you're looking at cost-benefit analysis, you'll go to a private hospital. And also, there's medicine in the private facility as compared to there being medicine in the public facility. So it forces people. The government is not saying you have to go to private, but the circumstances force you to go to a private institution.
Tie this up for me, okay?
Yes.
In your report, there is an implication, if not a direct statement, that seems to be saying this, that the government seems to be investing more in private healthcare than it is in public.
Yeah, that's the...
yes. Okay. I want you to walk us through it because we know about the Abuja Declaration.
Yes.
Everything you say is absolutely true. But how does that translate into the government funding private healthcare at the expense of public healthcare?
Look at the public-private partnerships that we have. For example, this deal we got into to have equipment.
NES.
Yes.
The managed equipment scheme.
Yes, managed equipment scheme. You see the amount of money that goes into that, if it would have been channeled into provision of to payment of doctors, for example, if it would have been channeled to purchase of medicines, it would have been channeled to construction of hospitals and actual direct purchase, which would have been cheaper than this licensing that we have, then you can see clearly that someone is using public resources to actually finance or to empower private sector.
I don't see. How so, Dr. Look, you've just mentioned other things. It could have been used to build a hospital.
Yes.
Someone would have been contracted from the private sector to do the job. It could have been used to buy medicine. The government does not have pharmaceuticals. It would have used the private sector that produced the medicine. This is about equipment. Even if you build a hospital, you'd have to equip it. The equipment is not manufactured by the government.
It has to be outsourced.
It has to be outsourced from the private sector. So how is going to purchase equipment supporting the private sector as opposed to or to the detriment of the public?
It wasn't quite a purchase because a purchase would have been a direct. This is a lease, and a lease
Yes.
that is more than 5 times expensive than an actual direct purchase. So if you look at it in terms of the value for money that the Kenyan taxpayer received from this particular actual contract to lease these particular contracts, you see we lost money in this particular context to a private institution providing these services. Yes, I accept that even procurement of medicines is from private institution, pharmaceuticals. But if you're looking at value for money, and this contract to lease equipment was actually assessed and analyzed by our Senate, and it found that it did not meet value for money for our taxpayers. So in that way, we lose resources that would have been used to better equip and empower the public sector to actually provide health services to its members. But that's one.
Mm-hmm.
The second one is NHIF. We have NHIF, which is the public insurance scheme that has been put in place to ensure that people are able to get access to healthcare. But if you look at how it has been implemented, we know for a fact that NHIF pays higher for private hospitals than it pays for public hospitals. And if you're looking at the amount of money that then goes to the private sector from NHIF as compared to the amount of money that goes to the public sector from NHIF, you can see clearly that the government is subsidizing the private sector.
How much per year does the NHIF pay, public versus private?
I can get you that information.
It's because you're saying that we know for a fact that it pays higher. Give me an
Yes.
example. If it's a dialysis, for instance,
Yes,
dialysis is paid at what, 9,700? We were looking at that story the other day.
yes.
Are you saying that it's less? Does NHIF pay less for dialysis in a public hospital than it pays in a private hospital, or does it pay a uniform amount? What exactly are you saying, that the NHIF pays more in private sector than in public?
If you look at the total quality of care that someone will get doing dialysis, the amount of money that he'll be charged in the public sector vis-a-vis the private sector, you'll see that the cost of dialysis in the private sector is higher, almost 12 times higher than the amount of money that you'll pay in a public hospital for dialysis. And that means if you're using NHIF will have to pay the private facility 12 times higher than it would have paid.
Does it,
But
Dr.
Dr.
I
Rago-
thought
Dr. Rago,
it pays a standard fee, whether in public or private.
It's not standard.
Even if it isn't, Dr. Rago, healthcare in the private sector will always be more expensive than the public sector. So if indeed you have an NHIF cover and you go to a private hospital, whatever matrix they use for paying, whatever system they work out, if you are in the private sector, you're in a private healthcare facility, you will pay more. So what you're saying is this: NHIF is then tasked to pay more because that is what the private sector demands. So because of that, public resources are actually being taken to a private institution as opposed to a public institution. So should the public institutions charge more?
Not necessarily. Not
To be
really.
at par.
Yes, so that everybody gets paid the same. Yes.
Not really. What we are saying, and this was also said by the Nairobi Metropolitan Services Director, he said that NHIF should actually be used in public hospitals and not in private hospitals. One, to encourage people to use the public hospitals, and two, to channel those resources to the public sector so that the public sector can then use the resources to improve healthcare.
Dr. You're now walking into the very, very murky and thorny realm of people's rights. Because you cannot tell people that you have this facility you've paid for, and you must. Even when they limited them to certain hospitals, meaning if you want, that's what NHIF does. If you're in this scheme and you have this particular need, you're told these are the hospitals in this particular area that you can go to. It limits it. Now, think of a situation where you're telling them you actually will go only to public hospitals. And the problem with public hospitals and why it is private hospitals are popular, we know why. But I want to move away from that discussion.
Let's take a break.
Hey, Eric, you've got me mid-sentence.
Yeah.
Okay.
Because I've seen where you're heading. Conversation continues. This is a Situation Room on SpiceFM, and also broadcasting and live streaming the show online, SpiceFM KE on YouTube, on Facebook, and on Twitter. We are discussing a report titled Wrong Prescription, the Impact of Privatizing Healthcare in Kenya, authored by Haki, Jamii and the Center for Human Rights and Global Justice at New York University. And the co-authors are with us in the studio, Dr. Nicholas Orago, who is the Executive Director of Haki Jamii, and Rebecca Riddle, who is from the Center for Human Rights and Global Justice at the New York University. Citi, before you took the break, I cut you off mid-sentence.
Actually, Dr. Orago seemed to have also divined the direction I was heading towards.
Okay.
And he wanted to ask his question or respond. So, Dr. Orago, over to you.
Thank you so much. Yes, we were discussing about
You heard some out
the
of court
public-
settlement here.
Yes.
public versus private, and I was asking in the context of NHIF, and I was saying that if you look at where we are now vis-a-vis where we were before 1990 structural adjustment programs, all of us used public health facilities, all of us used public schools, and public services made us equal because we could access services at the same rate at all the public service places that we went to. But with the structural adjustment programs and the reduction in government social expenditure that was forced on us by the international financial institutions, we had, in essence, creating a gap where government resources, social financing went down. And because there was a gap that was then created because of that lack of financing, then we had the private sector coming up to take up the space that was left. And so we have almost a divergent system of service provision where the rich have access to very high quality care and the poor have access to very low quality care. And that's what we need to go to respond to and go back and address. And that's the reason we're asking for more investment in the public service.
Daktari, I am one of those people who keeps talking about this. I say public funds should not go to private, either in education,
Yes.
in health. But there's no policy that does that. Even when you talk about the 90s and then the SCPs came in, there's no policy that decided to defund the public health sector or the public education sector. No policy.
Actually, Daktari, what you say has a lot of truth to it. But if you look at the changes, you asked me off air, what changes did we see? Well, what we saw was something very simple. Government employees, state employees became businessmen. And they became one and the same with businessmen. So when you talk about a middle class and you talk about the wealth in this country, many of them are civil servants, many of them are public servants, and many of them don't really have any business that creates value that you can point to and say, this person produces nails, this person produces fake hair, this one produces spare noses. There's nothing, very little that you can look at that can point to how it is they've got their wealth. But we know how they do this. Now, because they're in positions where they can direct the wealth of the nation, many of them direct the wealth of the nation in places that benefit them. You asked the question, how did it happen? That's how it happened. So that you will find, if it's a private school, you'll find some government official somewhere also owns a bit of it. If it's a private hospital, you'll find some government hospital, some government official who is the Ministry of Health has a say. Distant, but they're there. Now, so long as you have this interesting dichotomous situation, the situation that you refer to will continue. Because even as we speak, some of the biggest cash cows we've had in this country have been public institutions, NHIF, NSSF. So, our civil servants are business people, okay? And there is no law that prevents them from being business people. Enough said. I want to ask you this question.
Yes, please.
I read your report. And I looked at your sample size. I looked at the selection you made for the individuals who were interviewed. In that whole interview and the selections that you made, I didn't see. Maybe it was there, but I didn't see it. That's what I'm saying. I didn't see. How many doctors did you interview? How many private sector players did you interview? Yes, Ministry of Health are mentioned. Okay. Community health workers are mentioned. Yes, they're really mentioned. Activists are mentioned. Civil society people are mentioned. I say this because I'm now saying that it appears that there was a bias in this entire selection.
Thank you. A bias. Well, I confess in a way I am biased. I'm a human rights lawyer. What I'm looking at is whether or not people's human rights are fulfilled. And that's a question that starts with the rights holders, which in this instance is community members, and specifically the community members that we met with in Isiolo, in Mombasa, and Nairobi. So the question really starts with, are their rights fulfilled? And certainly, we did over 180 interviews with healthcare users and providers and government officials and experts and private sector representatives. But the bulk of our time is spent with community members to understand how they experience access to healthcare. Because the question of whether or not somebody's right to health is fulfilled really has to do with, are they able to access quality care? Are they able to access affordable care? Are they able to access care that respects their human dignity? Of course, because it's a policy issue, we also need to look at, what is the state putting towards this? How is it being used? Is it being efficiently used? What is the experience of healthcare providers? But in that way, our main concern is, are people able to access the care that they want and need? I'd say we could go through the methodology section, and I would certainly be happy to. But I think it was probably a handful of private healthcare workers who are quoted to some extent. However, I think our report is also based on over a year of extensive desk research. We subject it to expert review. We wrote, letters to every public official we could and asked for responses to information. So, I think particularly because I do come at it from a human rights perspective and have strong feelings about how some of this stuff plays out, it's incredibly important to us that we be really scrupulous with our work. So we stand behind our findings, but we certainly would invite pushback from, any doctors. We had a reviewer from the Kenya Medical Association offer comments. So yeah, biased? I do support the right to health, so.
But a bias in research sense is not a negative thing. So long as one comes out and says, look, this is the position that we are coming from, so this is our bias. Because if you talk about a selection bias, when you then want to confirm the data, the bias will also follow through. When it comes to publishing, the bias will also follow through. Nothing wrong in the bias being there, but it must be stated. Mm-hmm. When it's stated, then aha, this is where we are coming from. If it isn't stated, then you get the impression that a very balanced approach to the entire process, where everybody had an equal shake, and not everybody had an equal shake when it came to what? Seeking information. Information was gathered more from one sector of the society than another.
Was that the case?
I don't think that's the case, because we actually, at Haki Jamii, we did the actual discussion and interviews with the community members. And we did not only have the community. We also talked to service providers, and service providers we mean doctors, and not doctors just from the public sector, but also from the private sector. And we gave opportunity to government officials, and actually interviewed government officials, both at the national level and the county level, and gave opportunity to the financial international financial institutions, Bill and Melinda Gates, the World Bank, the International Monetary Fund, as well as the government, the embassy of the Netherlands. We gave them an opportunity to speak with us. We sent out letters with questions, and some of them responded, some of them didn't. And even today, after this show, we continue discussions with the Director of Health, Dr. Amos, in his office at 10. So we gave an equal check to each and every person to be able to respond to the questions that were asked.
So let me say this. Do I understand you to be saying, therefore, that the report then takes into account all these perspectives that you say you sought, and that the respondents, whatever they had to say, their contributions play an equal role in the report? Is that what you're saying?
Yes, it does. That's what we are saying.
That's what you're saying.
We were very balanced in our analysis, and we were very open to each and every person that we were speaking with as to what we were looking for. And we asked them the same questions. They had the same responses, and we analyzed and collected and analyzed those responses. And that's what this report is about.
Let's talk about the three areas that you mentioned that you see the government is directly or indirectly supporting the privatization of healthcare. You said there is promotion, there is policy, and there is financing. Okay. So what policies do we have in the country that have touched on this, that show that there is going to be support either directly or indirectly for the private sector to continue growing as opposed to the public sector? Is there any policy that we have in place?
If I may, there are a number of policies, whether it be the Vision 2030, a number of policy documents that sort of enshrine a commitment to increasing the role of the private sector, that explicitly state one of the government's goals is increasing the role of the private sector. And that's not a secret. It's a very common stance of a lot of governments, is to increase the role of the private sector in providing certain services. So I'm not suggesting that in itself is a scandal, but I do think it's an incontrovertible fact that it's a goal in policy documents. When it comes to financing, we have made a number of information requests to try to get a clear sense of the full extent of the amount of public money that's going to private coffers. Frankly, it's very difficult to get a sense of the full extent because there are just a number of initiatives. And so what we can do is kind of compile those and provide the best estimate that we can, which is that at least tens of billions of Kenyan shillings are going from public coffers to private hands.
At least what percentage of the health budget is ending up in the private sector?
That's a substantial amount, but until we have more precision, which we've asked for and we think is an incredibly important goal. That's one of our asks and one of our recommendations is greater transparency in this. And until you have precision, you simply can't say. And this is a common issue for Kenyan researchers as well. If you look at, for example, the Kenyan Institute for Economic Affairs has done a tremendous piece of work looking at the value for money of the Managed Equipment Services project. But they too would say there's no way to get this information to understand the full cost. The best they can do is estimate that it's an approximately $500 million US dollar project. So based on the best possible estimates, we can say it's at least tens of billions of shillings a year. But we would also anticipate it's more than what we know. And we would ask that the government make this clear.
So you haven't been able to narrow down and say, in our estimation, maybe 2% or 3% or 15, 25% of the national health budget ends up in the private sector.
Yeah, I mean, I think...
Are you able to actually to estimate, to put a figure?
The challenge with that is that information isn't publicly available. And so it would require looking at A, tax breaks that are given to the private sector, B, having greater transparency in public-private partnerships, C, greater transparency in how much the NHIF spends each year to private facilities. And just to go back to that briefly, I mean, Certainly, where there are where the NHIF's reimbursement schedules are published, there are services where the NHIF absolutely clearly reimburses private facilities at higher rates than public facilities. And there are various media reports and information given on background about how much the NHIF sends to the private sector, and it's clear that they send more to the private sector in claims money than public money. But at the same time, that information is, or to public facilities, at that same time, that information is not available and transparent in the way that one would hope to really be able to say with precision, I can tell you 15%, 30%, etc. And I think
I'm
that
looking for
itself
specific
is an
examples,
issue.
not
Yeah.
necessarily the specific numbers, because you say you conducted a lot of desk research on this, and then you spoke to various people, various stakeholders. So maybe you could be pointing us towards a certain direction. Say, for example, in terms of tax breaks, the health sector, private sector enjoys this kind of tax breaks, this tax break, and this and the other. Or I say there's a government project in the healthcare in health system that is also being run in the private facilities, and this entire entire health project is funded to the tune of, let's say, 100 billion shillings.
Yep.
And then we can see substantially some of that money is going to the private sector. Is there any example that you can use to go with?
Yeah, I mean, I think just as one example, so between the financial year 2016 and 2019, the NHIF sent 82% of its claims for outpatient benefits to private facilities. And for its inpatient claims, it spent 64% on inpatient benefits. And so that's what we're talking about in terms of extent. Like, that's a massive amount of NHIF money that's going towards private actors. And I think that's important to keep in mind. And when it comes to, for example, the Managed Equipment Services Project, that's $500 million is the best estimate over time that the Kenyan government is going to send to private companies. And I do think there's a real intrinsic difference in a long-term public-private partnership that commits the government to spending this money than simple one-off procurement. You know, you want to buy something at a reasonable rate, okay, great, from the private sector. If that provides good value for money, fine. But a 5-year or 7-year contract that the government can't get out of without incurring massive fees, where the private sector is really in the driver's seat, I think those are the kinds of phenomenon that we're really concerned about here. Because as you see with Managed Equipment Services, this committed so much money to a massive rollout of medical equipment that often ended up going to places that couldn't use it, didn't need it, where it wasn't really able to be utilized. And I think the concern there is that it's more the private sector's interest that we're driving that program than it is the actual need experienced on the ground.
You know, we debate that very often here, and the private sector influence is clear. They're business people, but we never leave out the role that the bureaucrats who are charged with ensuring that these things work the way they should. Because in this very city, in this very county, we've had a situation where they've had some turnkey project. How many? 24 health facilities, Eric? Or 21?
Yeah, 21, I think.
Where they've had contracts where you simply don't build the hospital, you build and equip. 836 million, not billion, shillings. Finished, completed, functioning. So, it could have been done. But in the absence of what we call the lending hand from those in government, there is no way we'd end up with the sort of contracts you're speaking of. And again, that has been the subject of discussion here as well. These contracts that always have us at the receiving end. You were saying something, Dr.
Yes, I wanted to give an example of a public-private partnership that has land belonging to Kenyatta National Hospital actually being used to build a private wing at Kenyatta National Hospital. So who is going to benefit from this? This is public land being given to a private person in a concession for more than 20 years. And then when people go to Kenyatta National Hospital, they will be sent to the private wing, not to the public wing. And who is this going to benefit? I agree with you that our bureaucrats are actually the problem, because their interest, which at Chapter 6 of the Constitution has tried to address, has actually not been addressed. And we have government officials doing business with the government itself, which is conflict of interest. And this has led to catalyzation of different sectors of society and has led to loss of funds through corruption. It's the reality that we have.
Doc, Are you saying that private-public partnership is public financing private?
In most instances, if you see the amount of money that the government is actually putting in terms of either tax credits to the private institution or giving incentives, equity incentives to the private sector, it's quite a lot. Look at land in Nairobi. If I was looking for land to build a hospital, how much will that cost me as the basic investment of buying land that I can use to build a hospital? But I'm getting this land for free from the government, and I'm given a 20-year concession to get money
But
out of the hospital.
Is it geared for public good or for private gain? Because again, that's
Or
where
is it a mix of the two?
Or is it a mix of the two? That's where the balance would lie.
If you look at our report,
otherwise, it would be a communist state here, where the government is the only one that's offering all the services.
If you look at our report, we say the private health facilities are for profit. So their aim, in essence, is profit and not the public health vision that we have. So yes, it will create a facility, but will this facility be accessible to members of the public in terms of the cost that will be required for them to be able to have access to this particular private wing of the hospital? Why not fund the expansion of Kenyatta National Hospital in this land and have it as a public hospital that is accessible to all?
By borrowing money from the private sector to fund this. Same difference, Doc.
It's not the same.
You know this private-public partnership, if you look at them carefully, okay,
Yes.
they're intended for public good. Because the government acknowledges the things it can't do. Sometimes it's contrived, but there we are. Now, when we want to get granular about the details of how these things work, where it gets murky is not where the government has the land and you have the money. No, it isn't that. It's the fine details of that
the contract.
Yes, that is where the problem is. The broad picture, very good. And some of these problems only come about when our contract is about to come to an end and somebody says they weren't paid over this period of time. Then
And
suddenly
they need to be compensated for breach of
and
contract.
they wonder,
all.
what are we compensating you for?
Ladies and gentlemen, we thank you very much for joining us. 1 hour is a short time, isn't it?
That was great.
But it's a good enough time for us to actually have gotten a glimpse of your report and what you're talking about. I see Dr. Simon Kigondo is asking where he can get the report, how he can access the report. I think you'll respond to him on Twitter as well and say everybody who wants to access this report where they can get it. Rebecca Riddle from the New York University School of Law, Center for Human Rights and Global Justice, thank you very much for joining us. And Dr. Nicholas Orago, the Executive Director of Haki Jamii. Asanteni sana.
Thank you so much
Thank you very
for having
much.
us.